Okay, so this is our OR recess review. Have all of you guys had the experience of doing an OR recess?
Once or twice.
Yeah, you night shifters do them all the time. So we're just going to go over a few things here. Review the admission criteria, any changes that might be happening. We'll do a little scenario that you guys can, let me know what you think's going on. We'll, if we have time, look at the level 1 and maybe a little documentation chat about that. So we'll start with the sort of overview. Back in the 70s and prior to that, San Diego was notoriously a bad place to get in a car accident. They had a very high preventable death rate at that time. It was like 21% from car accidents. And one of the surgeons, I think he was from Mercy, Dr. Virgilio, said at the time that you had a higher chance of dying from a car accident in San Diego than you did from dying in Vietnam, because it was very chaotic. There was, the paramedics, there was no sort of organized system. So in 1984, the preventable death rate dropped from about 21% to around 1%. And do you guys know why that happened?
Trauma.
That's right. The trauma system was implemented. We had already had a trauma center here. The trauma unit up on the 5th floor had already been here for quite some time, but they actually did an organized system with the catchment areas and base stations with the medics and all that, and that really made a huge difference. About a year later, they started doing OR recesses, and within a very short period of time after that, they found that the people who went to the OR with a penetrating injury and hypotension as an OR recess had better survival than those who did not. So they had success with that as well. And then they did more data analysis over the, over 20 years now, that showed basically the same thing. Not a huge amount, not really statistically significant apparently, but it was enough that we still do it, that it would make a difference in some of those patients, so they had better survival than if they did not go to the OR. So why do we do OR recess? Some of the issues were that the critically ill patients require immediate surgical intervention, so it's best to have them already there. Time delays can occur when you're moving from the recess room to the OR. I don't know if you guys have ever had a patient come to the recess room and then they decide right away, it's like, oh yeah, no, we need to do it in the OR. How long does it normally take you to do that? I mean, I think the shortest period of time is maybe 15 minutes, 10, 15 minutes, if the OR is ready, if they can get packed up and back on the gurney again and then over there. So even 15 minutes can make a difference, I think, in some patients. And then you have the problem of transfers. If you move the patient from the gurney to the trauma bed and then back to the gurney again, over to the OR, off the gurney onto the trauma or the OR table, you have all those opportunities to lose airways and lines and that sort of thing, which can be problematic as well. And then you have some patients that are obviously so unstable that the trauma recess and the OR needs to happen at the same time. So that's why we do it. And what are admission criteria? These have not changed a whole lot over the years, so you guys should be all familiar with this. So any patient who's in full cardiac arrest secondary to penetrating trauma, and then anyone in full cardiac arrest secondary to blood trauma who has had recent evidence of a vital sign. They may have lost that vital sign often, they're doing CPR, but they have to have some sort of evidence of it, whether or not somebody witnessed agama restorations, or when the medics got there, they had felt the pulse briefly or saw something on the EKG monitor, and then lost it and started CPR. Those patients can go to the OR. The issue with not having any vital sign in a blunt trauma patient is, like Dr. Bansal was saying too, is if somebody comes in with a ruptured aorta from a blunt injury, they're going to have no vital signs, they're going to be dead at the scene, and there's really not going to be anything that we can do for them. So somebody who's a blunt arrest at the scene, their likelihood of having any sort of survival is pretty slim. So you do not bring those to the OR. And then any patients who's hemodynamically unstable and unresponsive to pre-hospital volume administration, and that's been a blood pressure of 90 or less. Now, when the paramedics did their little talk today, they were talking about that they've made a change in their criteria in a couple of things, so that now that their blood pressure goal is 80 for them, but we have not changed ours yet. I've heard that there might be some talk about that, but nothing's been
I sent it out last week
Mhm.
to see if they wanted to make changes or not,
Uh-huh.
and that was going to be one of my issues.
Yeah.
And it's changed to 80. Do you want to change to
Yeah.
80?
Still waiting to hear if they want to change. Okay. And then again, the thing with the pre-hospital volume administration. Now that the medics are not putting IVs in until they're in the rig and determine a major trauma victim, there's not going to be time for pre-hospital volume before they get to us. There really wasn't beforehand, before they made the change, because a lot of times people would come in, they'd have their IVs in, but, there'll still be 950 mLs in the bag. There's really, with our short ETAs, not a lot of time for them to give big fluid boluses. So, a lot of the decisions that we make for OR resusces are based on pretty much minimal volume administration anyway. So, even though that's part of the criteria, it doesn't come into play a whole lot. It just possibly confirms, the suspicion that they really do need to go to the OR, if they're still hypotensive afterwards. Sometimes, that's why we get sometimes these patients that have the initial blood pressure of less than 90, they haven't been given any volume, but by the time they get here, they've had a little bolus and they're sitting up and talking to you. So that's always a little bit of a surprise as well. But again, you have to make the decision based on the information that you have at the time. So. And then any penetrating injury to the torso with blood pressure less than 90 systolic, again, that's the blood pressure cutoff for us. If they have major external hemorrhage uncontrollable by direct pressure or other means, again, they'll need to have some sort of surgical intervention to help with that, the bleeding. And if there's any direct airway injury or compromise, then they should probably go to the OR. Some things that are little disclaimers that we've had issues with in the past. If they have an amputation or evisceration without any blood pressure issues, with their vital signs are stable, then they don't need to go to the OR. They'll eventually will need to go to the OR, obviously, but they don't necessarily have to be resuscitated back there. If there's isolated penetrating trauma to the head, otherwise known as a gunshot wound to the head, generally they do not want them to go to the OR, but that's not always the case. So, sometimes it's, there's unseen injuries, other gunshot wounds, that they might have something. We had a patient come in one time who was reported to be an isolated gunshot to the head, and so we said, no OR, let's bring him to the trauma room. Turns out he had a big hole in his back as well. But the paramedics were really focused on the stuff coming out of his ears and all that, so didn't see that. And so the attending at the time, this is many years ago, was not pleased. So be aware of that there may be other things going on as well.
So just as a rule of thumb, should we make them all OR resuscitators with hemodynamic stability?
Yeah, it's hard to say because if they're absolutely sure that they've actually done the exam and they know that there's no other injury, and you have the luxury of time, maybe just calling the attending and see, what they want to do. But right now, as the criteria stands, that if it's an isolated gunshot wound to the head, then they should come to the resusc room. And if they have penetrating neck trauma and complete airway obstruction, then OR resus would be appropriate for them, even if they don't have hypotension. They're going to need to have some airway control that might be quite difficult in the resus room and would be probably easier for them to do in the OR. And especially, I'm not good at the zones of the neck, but if they have certain, like zone 1, 2, or 3, whatever the lower zone is where you can't get at it or something like that, I think they're more likely to send them to the OR just because there's too many structures obstructing things to be able to get the big vessels, so they need to have some urgent OR intervention. And then also, if the patient is a transfer from another hospital, if they meet the criteria, otherwise, then they should go to the OR. We've had a lot of people transfer from El Centro and other hospitals. They're very unstable, and they should go to the OR as an OR resus. And then you need to consider, too, what's going on in the trauma room. This is not part of the official criteria or anything like that, but some of the attendings don't like to split the team. So if you have a resus that's going on in the trauma room and actively resuscitating a patient, and they call for another patient to go to the OR, you need to talk to the attending, or the doc one, or whoever's in charge, the fellow, whatever, and see if they want to make the patient an OR resus or bring him to the trauma room. I know some Trauma surgeons do not want to split the team. They want to keep everybody there, even though that patient's going to be sick, but it's easier for them to manage 2 patients in the same location than it is for them to have to run back and forth from the OR constantly. So,
I thought that was
obviously,
I thought that was a rule on nights, just because there's less staff for them, because they still have to
That
call
could be.
somebody anyway. So I thought that was our. Is that still our?
Yeah.
That's what I- last I heard of it.
They don't really split the team anymore.
yeah. Now day shift sometimes they do,
Yeah.
but it depends.
I think there's more people like.
Right, there's more
other
people
attendings.
around.
Because
sure.
otherwise you have to wait for the backup attending to come
Mhm.
on. So people in the
Right.
meantime they're running between 2
Sure.
hours.
Right. Yeah, and so, yeah, and you also have the luxury of having, you know, if you've got a recess going on, you can just talk to them,
Yeah.
you know. So, yeah, that's good. It's good that you guys are already on. Because it is, I mean, we would have to wait, you know, for the next team to come in. Sometimes years and years ago, they would call in a second team and all that. So it does get to be a little tricky sometimes. Some other triage issues. What else? Oh, that was it. That was it on that. Okay, so when you get the call, the main part about deciding whether or not the patient should go to the OR is to make the decision and try not to change it. They really frown on re-triaging just because it just it gets very confusing. If you get a patient, get a call for a patient who qualifies as an OR recess and their ETA is 2 minutes, then they can go to the OR. If you have a patient who has a 10-minute ETA and you decide that they don't need to be an OR recess, they're just a regular trauma, you bring them back to the recess room. If you get an updated call on that patient and they've deteriorated and you think that now they qualify as an OR recess, you need to make sure that the updated ETA is 5 minutes or longer. Otherwise, we can't re-triage. So if the ETA on the updated one is less than 5 minutes, they need to stay with their original destination. Okay, because it's just too hard to scoot people back and forth. And then it gets confusing because the MICN has to call the medics and tell them, we've changed the location, you need to go here. And if they're already, you know, in the hallway, it's going to be hard to catch them. Let's see, what else with the criteria issues? We've already talked about this stuff. The blood threshold might be changing, so we'll wait to see on that. Isolated gunshot wound to the head, still kind of not really cut and dried. You know, none of this really is, you know. Especially sometimes when you get, you know, the reports that you get, not a lot of information and it's confusing and, you know, you get one story on the front end and when they come in it's like, oh, this is really what happened. So you really, I think the main thing is to just try and make the best decision you can with the information that they give you. That's really about all that we can ask for sometimes. Okay, so let's do a couple of scenarios, a little triage quiz, and you guys can tell me where you think the patient should go. Okay, so we have a 24-year-old male. He's a Peds versus Auto at 35 to 40 miles an hour. He's alert and oriented ×2, obvious right knee, left ankle, and right forearm fractures. He has chest and abdominal tenderness, left head lag. Heart rate's 102, respiratory rate is 18, and there's no blood pressure available. ETA is 15. What would you do with this patient?
Recess
Or
Versus one.
Okay, we have a little bit of both.
pressure
Hmm?
available or?
Right, that's one thing to ask is why is there no blood pressure available? They didn't do it, the patient's fighting them too much, they can't get it, you know.
I would assume your heart rate will be way higher.
Exactly.
In the
Right, if they're in hypovolemic shock or something like that, you think you'd have a more tachycardic response for most people. So those are all things that you can think about. But you also have a really long ETA. So you can ask them, can you please try to get a blood pressure and call me back? So if they do that, and they actually did do that, they give you an updated blood pressure of 102 over PALP. ETA is now 3 minutes, so what do you think? Whatever your original
Same
destination was, you have to
same,
stick with
yeah.
it. So if this guy was really, you know, you thought OR material because he really was hypotensive and they couldn't get a blood pressure because he didn't have one, and then you got a blood pressure that was over 100, but with a 3-minute ETA, then he would still have to go to the OR. So, okay. Next one, 28-year-old male, helmeted passenger of MCA El Centro, decreased LOC for 20 minutes, no blood pressure on arrival at El Centro. They put some IVs in, his blood pressure went up to 70. Has a wide mediastinum, a hemothorax, chest tube output was 2.5 liters, then the blood pressure dropped to 38. Patient is intubated and paralyzed. He's on maximum dopamine. He got 7 units of Paxils and 9 liters of crystalloid.
Oh,
Oh, this is-
Yes, definitely. Really have to talk to the transferring hospital and say, give
How
him some more
fast can
fluid.
you get? How fast
I
you can
know.
get here from El Centro?
Yeah, why not do the dopamine? You might want to give him some more fluid before you start that, but you know, that's a whole other issue. Okay, and then the next one, 45-year-old male, gunshot wound to the head, entrance in the occipital area, and also gunshot wound to the chest and left scapula. Blood pressure is 90 over palp, heart rate is 86, agonal respirations, and intubated.
Oh. Oh.
Yeah, he does meet the criteria, and he does have another gunshot wound. He hasn't got much of a, tachycardic response either, so who knows, maybe he's already herniated or something, or, but, so there may not be a whole lot they could do, but if he does have these other sorts of potential injuries they might be able to do something with, then he does definitely qualify for OR. Okay, last one. Code triage, there's a plane crash at Lindbergh Field. You have a 45-year-old female with massive facial trauma, burns to 60% of her body, possible C-spine fracture, blood pressure is 80 over palp, heart rate's 130, respiratory rate's 30 and labored, and ETA is 10 minutes.
Trauma.
No, trauma. Must treat everything.
Yeah, coach triage.
Go treat everything trauma.
Right.
oh.
Yes. Yes. So that was your question. So, I know. So if there wasn't this code triage mass casualty, this certainly would be a candidate for OR recess, but we totally changed our procedures for mass casualty incidents. If there's a code triage, then we become sort of the main location for the really bad traumas. And the ones that are kind of, lesser but still pretty sick would go to the PACU for shock and holding. And you guys know who staffs the PACU?
We do not.
The PACU nurses staff the PACU during a trauma code triage.
All right.
And Sharon, the trauma coordinator and the PACU nurses handle the patients, the trauma patients that go to PACU as shock and holding.
Huh.
We stay here and
So,
take care of the trauma patients. in the
When
resusc
there is a
room.
code triage, something big like that, nowadays there is the big organization I guess involved and everything. So does
Yeah.
the code still come the same way? Or it is, because last time when we had the big fire, everything went through
Yeah.
Dr. Tenza first to see who comes over. We didn't even accept anything. Everything went through him. How does that work?
Oh, did everything come through them? I don't think
Everything
it did.
he had to agree whether to bring the patient in or not because
Oh, I
That
don't
was
know.
the-
Maybe the first time. I was here for the second one, and they would call on the phone, on the regular trauma phone, and said, "We've got 4 more coming." They called as a regular call.
when I
You
came
know.
by the night, everything had to
Oh,
go
maybe
through.
by the
everything had
night
to go
time, yeah.
through Bruce because
Yeah.
whether they will be accepting the patient or not.
Oh, maybe. And we could have been sort of saturated by then, so I don't know if that was part of the issue.
We
But
had two patients
during-
in bed, 3.
Yeah, during the day, we had 4 that they were bringing by helicopter, 2 and 2. And so, we tried to get them to maybe, circle a couple of times. So, no, seriously, right? Obviously can't land 2 helicopters on the roof at the same time.
Yeah.
So we had a little bit, maybe 20 minutes in between or something like that, but yeah, they kept coming.
And I
So-
think there was a little bit of an informal agreement that we were gonna take the burns, but if it was
Yeah.
a stable trauma patient, that we would take the trauma patient because we have so many burn patients. So that might have been where Potenza came in
Yeah.
on that.
Yeah.
And usually when there's the multi-casualty for the county is called Annex D.
Yeah.
And then one base runs that call. And the incident commander on scene calls the one base hospital, and then they say where all the patients are going. And today, this morning, Captain Adams said that they were going to change that coming up soon. So
I don't know what they're
I
going
don't
to
know.
change it to, but yeah.
Yeah.
Because I remember during the fires as well, they had some lesser burned patients who had minor burn injuries, and they would be, I think, sent to different hospitals as well, to their ERs to have initial treatment, and they would be calling to find out. I believe is what happened, that they would be calling Dr. Potenza or the burn unit to see are they doing what they're supposed to be doing for these patients, and that kind of stuff. So. Yeah, the mass casualty all that often is kind of, runs like we would any disaster. So I don't know if you guys ever participated in disaster drills here. They ever been?
Yeah, they always call me.
on
I
that
said,
shift?
yeah, I always do that anyway.
We actually had patients come into the recess room and you had to, cart them all over the place and that sort of thing, yeah. It's a little different. We do speed through them, during the drills, but, we've had a few actual disasters, so we've, with the fires and stuff, so we've actually had to, handle it. Even on a busy Saturday night, you're gonna get that many patients all at once sometimes, and you have to handle it, so. Okay, so let's do a quick little scenario. This is actually a real patient that came in, I don't know, maybe about, it's probably been about 10 years ago now. She's just somebody that I remember quite clearly because I was in on this one. Anyway, so the MICN report comes in. There's a 63-year-old female MVA, restrained driver, and she ran into a tree at low speed. She was unresponsive at the scene. Her blood pressure was 80/40, heart rate was 92, respiratory rate was 20. They got a peripheral IV in and gave her 500 ml bolus. So we decided to make her an OR resus based on her blood pressure. When she came into the OR, the paramedic update was, similar to the initial report, but they also said there was minor vehicle damage and there were no external signs of trauma on this patient. So with her initial presentation, she was still unresponsive to painful stimuli. Her blood pressure was 70/palp, heart rate was 95, and she had, again, no obvious signs of injury. So what are we going to do for this patient? We're going to start doing the ABCs. So who's up there doing the airway stuff?
Anesthesia.
Anesthesia. Okay, so they're going to intubate, and what's the monitoring nurse doing?
Blood pressure, please.
Okay, and then Doc 1 is starting with primary survey, and then the other residents are probably trying to put a line in. Maybe you have another anesthesia resident trying to get an A line. So all this stuff is going on. Got some more IVs in, and the fluids are wide open because her blood pressure is so low. So at 5 minutes, they check another blood pressure, and by this time, I think the anesthesia and the monitoring nurse have fought over the blood pressure cuff a couple times. They take it off, we put it back on. So anyway, the second blood pressure was 80/palp, heart rate's 100, sinus rhythm. So they're continuing with the primary secondary survey going, what is going on with this lady? So they want a chest x-ray and a pelvis film to see if she's got any sort of internal injuries going on, and then somebody's sending labs. So then at 8 minutes, the monitoring nurse is again after another fight with anesthesia over the blood pressure cuff, did another one, and the blood pressure is now 200/98.
Heavy.
Heart rate is 120, and the patient remains unresponsive, so we're not really sure if they gave her RSI drugs or they just intubated her because she was unresponsive. Then the monitoring nurse has to slow down the fluids because now the blood pressure is too high, and they're continuing the workup on the patient. Another blood pressure at 10 minutes shows a blood pressure of 70/40, heart rate of 105, fluids are wide open again, and still they have not found any injuries on this lady. The trauma fellow at the time is like freaking out. He's like, I don't know what's wrong with her, what's going on, why is her blood pressure all over the place? He wants to see the chest x-ray to make sure she doesn't have, a ruptured aorta or something along those lines. He didn't really know what was going on. All her x-rays were unremarkable. She didn't have a pelvic fracture that she was bleeding. She didn't have anything on her chest, nothing. She didn't, have a C-spine injury that they could see. He was actually about 30 seconds away from doing a recess thoracotomy on this lady when I asked the anesthesia guys, so what have you been giving her? Because they weren't saying anything, but with those crazy fluctuations, like something else is going on. And he said that when her blood pressure was low, he gave her Neo because it was too low. And then when the blood pressure was 200, he gave her propofol to lower the blood pressure. So just the drugs that he was pushing was making her blood pressure go all over the place. And she almost got a recess thoracotomy because they weren't communicating this with the trauma docs. So just kind of a little point about, communication in that. And then we still had no idea what was wrong with her. Why did she crash her car? And at such a low speed, why did she injure? Yeah, she didn't have a history of anything. So come to find out a little later that she actually had a massive heart attack while she was driving. And she wasn't going fast, so she kind of rolled her car into a tree, kind of bumped into a tree, not really hit it hard or anything. So that's why there was really minimal damage to her car. There was no injuries, but she did have a big cardiac event. And thankfully we found out what was going on before they, opened her chest. Otherwise, she would have really been in dire straits. So, just kind of a little thing about.
Surprised I didn't see that in the EKG.
Yeah, I don't remember if there were any EKGs. There probably were some, but not a lot of people in the when we're back in trauma focus on that too much. Yeah, they're looking at the big stuff. So yeah, they did finally do 12.
What's the PR?
Yeah, we had
Maybe you see
something
those tombstone T-regs, maybe. But,
very similar to that. A patient was actually first tickled. And again, they were trying to for the whole thing, and the patient wasn't waking up, and then started to come around. But that was the same.
Yeah, it happens. It happens. So just in the interest of communication, try to at least if you see them giving drugs, maybe ask about what are you giving, or can you tell me so I can document it, or whatever. Isn't always met with open communication, but
How
at
do
least
we encourage this channel of communication with the anesthesia ward? Because they seem to have a set understanding of what needs to be done, but doesn't really jive with what the trauma protocol is.
Right, and I think one of the other gals that was in the group before was saying that she was actually at an OR recess where the anesthesia attending was there and was telling the resident, okay, this is not a time where you're going to be pushing pressors and stuff. This is, trauma we handle differently. It needs to be, we need to see what kind of fluid resuscitation they need, that kind of thing. This is a fluid issue. We don't need to do the drugs right now. So, I mean, somebody actually, heard them say that. So I don't know, when that happened or anything, but I know we've had communications over the years, about the conflicting kind of priorities. And, it's just kind of an ongoing issue that we keep talking about.
He's working with us.
Yeah, so I know they're trying to do what they do, and keep the patient on an even keel as far as that goes, but that's not really the way that we do trauma recess. We're trying to evaluate hypovolemia, that kind of thing. So anyway, communication. Okay, so the rapid infuser. Have you guys all used this?
Once or twice.
Once or twice, yes. Okay. So the big things with this is to make sure that when you load it up that the parts get put in properly to start with. You want to start with the thing going in the right direction, and it tells you 1, 2, 3, 4 where to put it. Here's number 1. Put that in number 2, and make sure this gets seated down properly because it can leak as well as beep at you. And then here, I know the one in the OR is a little different.
Yeah.
I think it has like a side thing, and and I hear there's a kinking issue sometimes that you have to be careful with how that's done. This thing can sometimes be loose, so I don't know if you guys have ever had this thing pop off on you when you're had it under pressure, but that's happened to me before. So I think with the newer tubing that it's not a lure lock. I think it's like solid on here. It shouldn't come off. It shouldn't be loose or anything like that. So, and then just,
I don't think I've seen anything in between before.
Really? Yeah, it's just an injection port. So, and then when you have this on, just make sure that you have to plug it in, obviously, or the pressurizing thing won't work. And if you're doing a lot of blood, back and forth, you really need to use the filter. Are you guys familiar with that little filter thingy? It looks like, I don't have one in here to show you, but it looks like this. And it has a little piece of like foam in here, like a sponge. It almost looks like black thing in here. And it's just their blood filter. We're supposed to be using it.
Where does it fit on that? On that end? Oh.
Yeah, you have a two-chamber thingy. And after every 4, you're supposed to change the filter out. That's really hard to do if you're giving massive quantities of blood. And sometimes they don't even have filters in there. So, if they have them, use them as much as you can. So
Does anesthesia stock that, or
they should. Anesthesia monitoring is supposed to stock all that stuff in the resus room.
For the first 4, we don't have the filter because you have the filter at the bottom there. And then after the first 4, then you start using filter.
Oh, I don't know.
Because then you don't have to keep, otherwise you have to replace it. Because they want you to give 4 units in the system, but you got the filter here to begin with. But then if you're putting a lot,
Yeah.
then you start adding the extra bit there for the.
Yeah, I'm not sure how big of a filter that is. Do we know the size of it? The bottom filter? I'd have to look. As long as it's, I guess if it's an 80
We were just
micron.
checking the OR card this morning. and
Uh-huh.
There are no filters that you're talking about, the gray ones.
Really? They didn't have any?
Was talking about
Oh,
filters,
okay.
that's what she
Yes.
remembers. But the only filters they had was that piece right there. And I guess
This.
you're supposed to just change it out.
Mm-hmm. Okay.
Yeah, because actually you can get that part as well.
Yes, as a
Separate-
separate
it comes separate
piece.
piece.
Right, there are extras of those in
Yeah.
there, in case that gets clogged. Yeah, we'll check that out and see, but,
You can change that out.
Yes.
Oh, from the tubing?
Yeah.
Yeah, you can climb above and climb below.
I was thinking of that.
Mine
little-
though was
But-
saying otherwise you'd
But if you just connect the
Yeah,
top part first and let it go through and then connect at the bottom. And then that'll
you'd
be
have to,
fine.
yeah, flush it, yeah, get all the air out and all that stuff, but yes. Yes, this is a level
that's the one.
1 filter with gas vent replacement. I'll have to check it out and see if they're the correct, you know, the correct kind of filters, so. What else? The really most important thing with this is that, that either the circulating nurse should be the one running it, or another nurse that comes in. I wouldn't give this to a medical student or any docs or anything, because they are, you know, they have other things they're supposed to be doing. So somebody needs to be on this and do nothing but that when they're running it, because it's the risk of air embolus is kind of high. Yeah. And when you're switching out from, you know, changing a bag from one to the other, don't forget to clamp it. I did that one time. Forgot to clamp it right here, you know. So this one was pumped up on air. This one I was taking out to change, and we had a little geyser of blood in the CAT scanner. It was great. It was great. It was.
John loved that.
It was a blood bath, yes. And I felt really bad because I couldn't clean it up because I was taking care of the patient.
Yeah.
So, anyway, just something to remember.
Our last or research, something
Yeah.
came up where the anesthesia saying we shouldn't be putting FFP through there.
Really? Why not?
Platelets.
Platelets.
Oh, did they destroy the platelets or something? Or? I don't know.
Well,
Hadn't
he
heard
said
that.
there was time, and then when we sort of looked around on the web, but couldn't really see anything conclusive evidence. Then he sort of backed up. I mean, I approached him again, but apparently this is coming up now. There's a lot of research going on where we shouldn't be putting stuff through there.
Why is that?
Haven't heard that.
I don't know whether it
Is
had
it the warming portion? Because
I don't
remember,
know
like,
whether it's the
hotline,
warming
they
He
Does
said
it
it had to do
want
with the pressure.
with the pressure and the speed it's been through, whether it damages any other cell. I don't know. But this is something the
Yeah.
first time I heard about it. I thought, okay, now something else we have to
Okay.
think about now.
Oh, somebody maybe
Yeah,
we can
ask
check with the blood
Grace.
bank or
Yeah.
something? Yeah, okay. Okay, we can find out.
They put it through a pressure vent.
Exactly. What's
Yeah.
the difference?
Yeah, we use push brake all the time.
Yeah.
And stuff, so.
Yeah, well, at the end of the day, you know, if you don't have a pressure, what's going to save the patient?
Right.
What's your primary?
Yeah, exactly. And are we giving platelets in that kind of a recess anyway?
Yeah, I thought it was
Sometimes
FFP
maybe,
though. I
but-
thought it was FFP
No, we gave
because you
lymph node.
gave 9, you gave 8, and then we had one more FFP.
We were alternating the 1 and 1, and then they told us to give us a unit of platelets, which we did, and the guy saw us put on the, and afterwards he goes, you know, you guys aren't supposed to be using that level 1 for platelets.
Huh.
It's something to do with the cells and the pressure of the bag.
Oh, okay. Well, we'll check it out and see. I had not heard that before,
That's your
so.
research.
Yes.
Quick question. Well, they didn't have any warm blanket in the OR, and apparently they don't keep them there anymore.
Oh,
In that
really?
room, in
What's
the OR 11
warm?
where the video is, we used to have blanket there.
Yeah, they were,
Was there
This-
fluid in there?
it was empty the other
It was
night.
empty, and
Oh.
they said they don't keep warm blanket in there anymore either. And like, well, what was who changed what?
What committee took it up?
Yeah. It's good to know. Yeah, because that was supposed to be.
Yeah, because you have to
back
run over
there.
to different room to get blankets. That's all I'm like, I don't even know where to get them.
Oh, I know. Oh, Sunday runner off.
Right across the hall, found that out.
Oh,
That one was the other
had that
night.
experience.
Everybody-
Okay. Okay. So the only other thing, real quick, is I don't know what time you guys are supposed to be finished. Are we past time?
I think we're the
Are we a
last
little
group.
bit? Yeah. Are you
No,
the
I
last
have to go to
group?
recess
There's
room.
one more.
No, you have one more.
3:15.
Okay.
3:15.
So just real quick documentation. I don't know what you guys do for documenting
Tape.
in the. Okay, so what do you do now? With we don't have any adhesive tape.
I
What
fill
tape
out
do you
the
write
whole-
on? Do you write on tape?
Right
still?
on the gown.
You use the whole flow sheet?
Right on the gown. Oh
You
yeah,
write
you're
on the
one of
gown?
the few. You bring the flow
Yeah.
sheet in.
Wow.
You have the KDM recess documentation. Huh?
I should have brought a clipboard.
You do?
handwriting.
Yeah, this is this is one that I did almost 20 years ago, and Peggy sent me a letter saying that she thought it was really spiffy
Wow, 93.
charting. Yeah,
Oh, Dr. Cushman, huh?
Dr. Cushman, Dr. Yang, and Dr. Edelstein, yes.
So did you have a scribe in those days?
Oh, heavens no. Those are the days where I would get the adhesive tape and make strips of it all over my lead and then write on it that way, and then, you reconstruct it later. That's just how I learned how to do it. If it works for you to do it on the flow sheet and you can get all that stuff in there and not have somebody, spilling junk on your flow sheet and throwing it in the trash or, misplacing it, whatever, then, obviously it's up to you, whatever works best. But for me, it's easier to do it that way just because you can have your little time block and you can put little notes about everything that you're doing. You put the vital signs, did they get intubated, are the docs doing cut downs, whatever kinds of stuff on their labs, that sort of thing. Counting the blood products as you go.
And you're totally hands-on as well. It's like
right, because your paper comes with you wherever you go, your documentation thing, and you can just scribble yourself notes. As long as you can read what you wrote, and your scribbles make sense to you, then you can go back afterwards and sort of reconstruct everything that happened. So that has worked for me in the past, and but again, whatever works for you guys. I don't know, at this point we don't have any more of that adhesive tape, and since they don't whatever happened with that, they just don't make it anymore. So you can't write on any other tape. But I guess if you write on the yellow gown, you could do that as well. So, but the most important thing with the documentation is to try and show that the reader what went on in the recess. Make it, tell the story of what happened, so that anybody that reads it can figure out what was going on with the patient at the time. So, if you can correlate vital signs to what blood units have gone in, and then you can look at the time when they did the blood gas, and then subsequent blood gases. We've had initially a base of -21, then we went to -11, then -8, and then we got worse again to -15. So if you can do stuff where you can put down the fluids as they go in instead of the grand total at the end, that's helpful to see how things are going during the resus. When they had to crack somebody's chest or, open their belly or whatever, if there was a change in their vital signs. When they clamp and unclamp the aorta, you should expect to see some sort of a, difference in the blood pressure, intubations, all that stuff. So whatever you can do to make it a coherent story about what happened, that's kind of the goal, I guess. So, do you have any questions about any of this?
good job.